Good evening, everybody, and thanks for joining us this evening on a session to ask the Management Executive a question and answer session. I'm sure that as it gets beyond 6 o'clock and clinical commitments finish, that we'll have more people joining us. It's probably a good thing for me to ask everyone to introduce themselves, I guess. So I'm just going to first of all ask people to do that, and then we can start very much with question and answer session from the people who are dialing in. So feel free to either use your chat functions or put your hand up, and we can have this as a very informal Q&A. So I'm going to look at my screen and work across and start with Lorraine, if you don't mind introducing yourself.
Hi everyone, I'm Lorraine, I'm Chief Nurse.
And Ewan?
Hi, I'm Ewan, I'm the Interim Chief Operating Officer and a gastroenterologist.
Hi Sue.
Hello, I'm Interim Director of Improvement and Transformation and a neonatologist.
And David?
Hello everyone, my name is David Werrett, I'm the Workforce Director.
Claire?
Hello, I'm Claire Stoneham, Director of Strategy and Major Projects.
Roland?
Hello, I'm Roland, I'm Chief Executive.
Stephen?
Hi, I'm Stephen Wallace, Divisional Director for Division C and Geriatrician.
Ashley?
Hi, Ashley Shaw, Medical Director and a Radiologist.
Mike?
Hi everyone, my name is Mike Keach, I'm the Chief Finance Officer.
Thank you. Afzal?
Afzal Chowdhury, Renal for eHospital.
Hugo?
Hi, I'm Hugo Ford. I'm an oncologist and Divisional Director for Division B.
Thank you. And I know Mike Moore is also on the line, although not a former member of the Management Executive, but as Chair of the Trust. And for those who don't know me, I'm Justin, I'm a Deputy Medical Director. Good. So I don't know if anyone online has any particular questions or queries that they want to kick off with, either with your hands up or using the chat function. If not, I'll make a start with a question that Richard Price, one of the plastic surgeons, sent in because he wasn't sure he could make it. Richard was interested in the 5 and 10-year plans for the Trust. And where we see ourselves in that time frame, in particular in relation to clinical care and the types of services we offer. Nothing too big or broad there, but that was what Richard was interested in knowing about. Roland, you've just taken yourself off mute. Does that mean that's something for you?
Only to say I'm sure that Claire's got a very compelling vision that she'll set out, and I know that Ashley will also want to follow up. If that's okay with you, Justin.
Over to you, Claire.
Thanks for that, Roland. Great question to kick off with. So I maybe start a bit around the kind of the Trust strategy. So we do have a strategy. Important, I think, to be clear about what it is that we're setting out to do, and to kind of use that to help organise and shape some of our work. We refreshed it last summer. It's been quite COVID focused, and it's something I want to do is to look at it again over the next few months. But we've been really thinking about it in 3 areas. So improving patient care, how we support our staff, and then building for the future. And I'll maybe talk just a little bit more about the building for the future area, because that's something that I spend probably more of my time thinking about. And there are sort of three main areas within that. So our major projects are a really, really important part of that, sitting underneath the Addenbrooke's 3 umbrella. And we kind of break them up into phases. So we've got a set of things that we're thinking about with a very kind of immediate focus. The Surge Centre has been one of those areas, and we've just seen the 20 new beds open within the last week or so. In phase 2, we've got the Children's Hospital and the Cancer Hospital. I think really important, really exciting developments for us. Both of those moving forward. We've got increasing certainty, I think, around the government commitment, around the university commitment. Lots more to do, but really great to see those progressing. And then we've just set out a wider vision in terms of the the sort of the broader site redevelopment that really says, well, what should come after children's and cancer? We've really thought about how we need to keep working with our system partners, how we can continue to build on our networks and relationships across the region. But to start really to say, actually, the next things we need to do is to think about our acute care, think about neuro, given the condition of the A block is in, and think about planned care services as well. And so we've just set out a kind of programme business case that sets out that roadmap for the development of the site. I don't think that's an immediate thing. I think this is going to be at least a sort of 15-year journey that we're on in terms of that development, but I think helpful to have a kind of overarching view of where we're going on those. I've touched a little bit on some of our work with system partners, and I think that's really important for me in terms of building on that, perhaps formalising it a bit more, increasingly trying to think about how we can care for patients better, not just within the hospital, but actually working with primary care, with community services. You know, we've started on that road already. It's not a new thing, but I think some questions about how we build on that and how we take it further forward. Ewan, you've been leading some work with our GPs on a GP roundtable. Sarah's been very involved in that as well. So that's quite an exciting area for us to think more about. And the other thing that we're doing as well, just really starting, I think, some work on at the moment, and it'd be great to have more involvement from colleagues on this call as we develop this work, thinking about our specialised services, how we work more closely with other hospitals across the east of England. So talking to Norfolk and Norwich, Esneft, Mid and South Essex, East and North Herts and Papworth about the collection of specialist services we provide across all of our trusts. How can we work more effectively together? How can we help more patients stay in the eastern region? How can we help patients be treated closer to their homes, at least for some conditions? How can we improve equity of access to services across the eastern region as well? So that's another big area of focus. And then I know I need to stop talking soon. So just the third area I'll mention is on the kind of the campus. I'll work with the university, research, innovation. I think that's a really big part of our strategy and where we want to be further developing over the next period of time. But sorry, Justin, I'll shut up now. And I'm sure there's other bits that Ashley or Roland might want to pick up.
No, Claire, that's really, really helpful in terms of an overview of direction of travel and particularly a realistic sort of discussion around timeframes, which I think is really helpful for people to have at the forefront of their mind. Ashley, I don't know if there's anything that you wanted to add there around the
I think
other
picking up on the
aspect of
themes
the question, which was,
that Claire
as
started
these
to talk about
developments
there,
sort of
Justin,
continue, do we still feel that
I'm just conscious that everybody's
clinical
just
care that we
frozen on my
provide
screen,
will
and I'm
be
not
the
sure if
same
that's me.
What just happened? Is anybody's here?
So I think those in the hospital have frozen, haven't they?
Yeah, we're here.
I'm here.
Oh,
Hugo's applauding. Afzal is with us. Aren't you, Afzal? Yeah.
Was it just me that fell out, or did everybody fall out?
I think quite a lot of people fell out. Everybody froze.
Okay, we're back.
I think we're back.
Excellent. Sorry.
I think Ashley was just talking us through.
yeah. He's just rejoining, I think, Justin. He's just
Yeah,
checked,
no problem. Thank you.
I hope.
Or if not, would anyone else like to take that, either Ewan or Lorraine, perhaps from a clinical perspective?
Sorry, I haven't been kicked out. I didn't know where we were, Justin. What was the question?
No problem. We were talking about whether we envisage the campus continuing to provide the breadth of care that it currently does, or whether realistically it might become more of a focused specialist centre with acute care, cancer and trauma, etc.
Yeah, I mean, obviously, there's a degree of uncertainty, but I think it is likely that we'll be delivering more care across the system and across the region than we are today. There's clearly going to be the need for the majority of services to be carried out on this site, but you know, we're all working differently now than we were 15 months ago. I mean, with virtual appointments, and I think patients will come to expect not having to come onto site for everything. So I'm sure that 80% of what we currently do on this campus will need to continue, but I'm sure we'll be doing more work in different places, networking with hospitals around the region. There'll be more focus, I think, on the work of the systems of Cambridge and Peterborough rather than just CUH. So, you know, whilst we've traditionally thought about the patients who've been referred here, I'm sure we'll be thinking more about how we deliver care to a whole population of patients. I think that will start to become a bit clearer over the next year or so, exactly what that looks like.
Ashley, I don't know if there's anything else you wanted to contribute on that clinical question on the campus, but I think you and May have just covered it.
Yeah, I was going to say I gave a brilliant answer, but no one heard a word. It was a true tour de force. I'm assuming Ewan talked about partnership working and maybe getting more into the role of addressing health inequalities across the system, and where our role is all the way through from health inequalities through to working with partners to develop specialist services. So I think it may be a much broader, more outward-looking CUH over the next 5 years than has probably historically been the case. And I think that's probably going to be the same for most teaching hospitals. I think as we probably will become to be seen as something of an anchor institution for the East of England, I think we just need to sort of try and set a tone for the East of England and to work with the regional teams to try and help guide and shape what the future of healthcare is across the East.
Roland, I wonder if I might ask you there in terms of the integrated care system, ICS, kind of that's in its sort of building phase, if you like. I guess it's fair to say, I think many consultants in day-to-day practice aren't really familiar with the concept of it and perhaps what impact it might have for them and their patients. And I wondered if there's anything further to add other than what we've just heard.
Yeah, so Mike Moore, the chairman, and I have led the integrated care system for 3 years this summer. So three years. Mike as chair both of the trust and the integrated care system, and me as chief executive of CUH, and then accountable officer for the system. I think in this next, and really what that's been trying to do is a lot of what we were hearing from Claire, Ashley and Ewan around starting to think not so much about patients, but as citizens, and how we can collectively use all of our expertise to keep people well, and when they get poorly, treat them closer to home and only really bring them to the hospital when we need to. And as part of that, Claire, I think your point around how we really work with the university and industry partners to do that in a different way. And Justin, we've been the only one of the 10 teaching hospitals to have that co-leadership role. And it was very conscious. It was a conscious decision to do that. Not just a protective, defensive move to avoid lots of people coming to hospital, but because we think it's the right direction of travel strategically for the Institute of Metabolic Science and the way that our cancer services and vision is developing. And, you know, I can see Andrew McCaskey is here, the way that he thinks about movement as opposed to just orthopedics. So I think we've been working very hard in that direction. As we move into the next phase, I think some things are going to change. So I think it's unlikely that Mike and I will be able to carry on formally as chair and accountable officer of both the system and the hospital, and we'll stay with the hospital. But the things that I think Claire and Ashley and you have been talking about are things we're still going to want to do. So if you were to jump forward 5-10 years to the question, I would hope that we've got a sort of single vision and a single provider for the population served traditionally by our district general hospital function. I would hope that that includes general practice, social care, community services, and the hospital services. And we've got that properly joined up. And one could imagine a world where that's a division of CUH. But I would also hope that we then got a series of specialist institutes on the campus, linking with the university and industry, with a sort of regional and national reach. And I suppose I mean, we may be being naive and we may be missing something, but we think it's okay to be able to step away from leading the integrated care system, provided we can deliver the vision we've just been talking about. And I think there'll then be radical changes in the way that we're looking after people, and the sort of work that AFSAR's been leading around our digital infrastructure. We're the most advanced digital hospital, or hospital from a digital perspective in the country. How that reaches out into the community will be very important, and how we engage with citizens in a different way will be important. So I'll stop there, Justin.
That's really helpful, thank you. If anyone online has any questions, please put up your hand or use the chat function, and I'll get those questions across. In the meantime, I might just slightly change tack, if that's okay, and just ask David and Ewan to maybe just ask to think about Ewan, perhaps from a recovery post-COVID, or well, peri-COVID perspective, where you think, or what you think the pertinent points are in terms of our recovery, Ewan, and David, perhaps how we balance that with the well-being, which I know we're all very mindful of our staff, balancing that sort of difficult juggle. Perhaps a couple of things to think about.
Yeah, thanks, Justin. Yeah, this is a really important topic. I mean, if I sort of break it down into very simple terms, before COVID, when we had more capacity, we were just about able to hold our waiting list steady, and much of the NHS was seeing the overall size of the waiting list increasing. Now, clearly, we've had two major things happen. Firstly, we've lost a lot of activity over the 2 waves of COVID, and we're not up to 100% capacity. So that presents us with significant problems, and you'll all be dealing in your day-to-day clinical lives, as I am, with patients who are waiting very, very much longer for treatment than any of us would have wanted. So I think there are pieces of work with, several of the people on the call here are leading pieces of work around delivering the maximum amount of elective surgery, for example, or diagnostics, or using our outpatients as effectively as possible. But we need to be really mindful that everyone is pretty exhausted after the last 15 months or so, and striking that balance is really, really important, because it's going to take us realistically several years to get on top of the various waiting lists, and we won't achieve that by just working people as hard as possible. But of course, at the same time, we're all facing that dilemma that we've got patients who've waited a very, very long time. So we're trying to maximize what we can do in the hospital. We're sort of working where we can with other providers, so where there is perhaps a mismatch between the capacity available at different places, or longer or shorter waiting lists. So for example, if we compare ourselves to North West Anglia, we've got longer waiting lists in some specialties. So for example, in orthopedics than they have. They've got significantly longer waiting lists, for example, in ophthalmology than we have. So we need to try and work to maximise all of the capacity in the system. But as I said, it's really, really important at the same time we don't do that by just getting a big bullwhip out and working people harder.
Thank
David,
you.
I don't know if you want to add to that.
Justin, shall I continue with?
Thank you, David. That'd be really helpful. Yeah, thanks.
So I think Ewan has sort of led the story. In fact, the plan that Claire's outlined has led a story about the importance of focusing on the workforce plan for the organisation, and an important part of the workforce plan for the organisation is around health and well-being. And we've talked about the next, the phase of recovery, hopefully a sustained recovery, is a marathon, not a sprint. But sometimes the passion and excitement of our people and the concern for our people about patients means that it becomes very much the now conversation, the extra day, the 7-day working. And we want to be really sure that we are planning for the future to support people to be well over the coming months after the journey we've been on. So clinical leaders in setting the tone for the well-being of our workforce is really important. We know that physical as well as mental health are going to be important to us. We have set out a series of investments that we will be making, including specifically around mental health for our workforce. And that's very much on the learning that we've had over the past 12 months. Also, as we know, vaccination and other aspects of the wellbeing agenda have never been more important, and that will stay with us over the coming years. I would say the wellbeing agenda has become the #1 focus for many organizations on their workforce agenda. And there are streams that fit beneath it, such as ensuring we are as fully staffed as we possibly can be. But the nub of it is, have we got a healthy, safe workforce that can deliver what we expect them to deliver and not compromise on their health and well-being or patients' safety as we move forward. So ideas, approaches, things we're missing, please do shout about, but it's absolutely the top of our agenda over the coming months and years.
Thanks, David. And Lorraine, I guess it's fair to say that this is equally important across all members of staff in the hospital.
Yeah, I mean, I think just to add to David and Ewan's point, I mean, staffing is challenged, particularly nurse staffing, particularly in some of our ward areas, which I'm sure many people on the call will be well aware of. And I think it's fair to say that we are trying to balance the need for additional capacity and additional throughput of patients and that of the well-being of staff and the safety for patients. So every decision that we make is based on that difficult balance, if you like, around do we have enough staff to open all of these additional beds. So most people will know that we haven't actually opened all of the beds, have we, Ewan? There are some that remain closed, and they remain closed because we cannot safely staff them. And we could push the staff more, but we have that fine balance of also maintaining the well-being of our staff and the psychological safety of our staff and safety for our patients. So it's a big challenge at the moment.
Thank you. I don't know if anyone else wants to add anything to that. Obviously, it's a big topic. Roland?
Yeah, so I agree with everything that's been said. I suppose, Justin, I mean, traditionally, what we've been able to do, I mean, David and Lorraine, I think, managed to get our nurse vacancy down, David, from, I'm going to say, approaching 20% to around about 4%. And I mean, Steve, you and others, and Ewan and others led quite a lot of work to, in effect, create more capacity within the hospital through things like the development of the acute hub and, you know, other leadership around things like delayed transfers of care. And that was really trying to push towards being able to contain different parts of the hospital. And I suppose where we are now, Justin, is I think, you know, people like Claire, Karen, Mike have done a superb job. I think we've got over just under £100 million of capital for this year, which is giving us the 120 beds. For the 40-bedded unit on the 20 land, we want to put 3 laminar flow theatres to support orthopaedics. And we need to recruit to have that capacity operational. But I suppose what you're really hearing from David is there's a huge amount for us to do that's more than that. And I think the listening exercises, the support to staff has been incredibly strong, but we're musing at the moment on, we think we need to do a lot more. You know, the experience of some of our colleagues in critical care, some of the colleagues have been moved around a lot in the hospital, and what people have gone through personally, I think needs another swing around the buoy. David, I think that's what you're alluding to. And we're thinking about that at the moment.
I was just typing in the comments, Roland, that I mean, part of the CUH story is year-on-year growth for 252 years in its workforce numbers, and it's never quite enough. And we always push just a bit further. So we were looking at numbers earlier on. The last 3 years, we've seen an 11% growth in our workforce. The past 12 months, approaching a 4% growth in our workforce. Against that incredible year we've just had, we keep on growing and we keep on delivering more services. And so it is a numbers game, but it also is a game of us, if it is a game at all, of course, which it isn't, is leaders absolutely paying attention to how we use our staff day in, day out, how we support our staff, how we pace ourselves, how we ask for help and how we respond to requests for help. I mean, that's part of the CUH story as well. It's going to have to be writ large over the coming months.
Thank you, everybody who's contributed there. As you say, hugely important and at the front of everyone's minds, clearly. So thank you for that. I might just move to Sue Broster, and whilst we acknowledge the challenges there, that there's also excitement around transformation and development, and of course some of the challenges over the last 18 months have brought things that we'll no doubt keep with us. And so I just wondered if the sort of IHI side of things and the sort of exciting issues in transformation and QI that are sort of happening is something that you might want to talk about and highlight to people in terms of their services and how we move things forward.
Yeah, no, thanks, Justin. I mean, I think it's fair to say there's been an immense amount of transformation of services over the last 12 months. And some of what the IHI wants to do is really capture that enthusiasm and slightly perhaps formalise the language, not in a way that makes it oppressive or difficult to use, but just so that some of that information can be shared across and between teams, both within the hospital about how we improve and how we learn and how we transform, but also with our system partners. So Ewan has clearly been instrumental in getting the work with the IHI, close to the point of launch. And I inherited the lucky part of actually launching it and working to select the teams. And there's been some phenomenal applications from clinical teams thinking about some of our really tricky problems that we've been facing for a while. So things like some of the flow, pressure ulcers, falls, and real multidisciplinary, multi-professional teams. So not just a particular professional group, but working across medics, nurses, allied health, and operations. And also tackling some new challenges that perhaps we hadn't really had to face before. So thinking about, for example, long COVID and working well beyond the sort of traditional, if you like, environment of just the hospital, and Rowan Bernstein leading a team working across the system. So community partners, primary care, CPFT, NWAFT, together to think about how we care for a group of patients who 18 months ago we didn't even know existed. So some really exciting innovations, and also an opportunity to learn from that about how we might do that for other aspects of care. So whilst testing that with, for example, long COVID, a real opportunity to think, how might we do that for other conditions that might span across well beyond just the traditional hospital area. Alongside that sort of first wave for programs of work, there's also been 45 coaches. So again, people who are particularly interested in improvement to start to work in clinical teams. And again, many of them are a range of different clinical experts. So nurses, ODPs, medics, operations teams, some from within the hospital, and again, some from outside the hospital, to start to build those relationships and bridges about how we improve care for our patients, not just within the hospital, but working, as I said, much more widely across the system. And they've come with individual projects that they're particularly focused on to start to work with teams. So quite a lot of change, but in a way where people are really leading that change themselves, with support from the IHI around how you can do that, how you can measure that, how you can see a real improvement, but also not to be scared that if it doesn't work, to stop that pathway and go down a different way. And perhaps one of the things that I reflect on it as an organisation, we sometimes wanted to start with a almost perfect approach, and actually the IHI is taking us back to have a think, have a go, test it. If it doesn't work, try a different way. And actually that's a really positive way of thinking about how we can make small changes to really improve the services for patients we're looking after.
Thank you, Sue. And I think that ties in really well with John Berwick's session that obviously you and Ewan kindly arranged for everyone last month. It was interesting where he mentioned often some of the obstacles that are in the way, and some of the things that sort of annoy people day to day and they just wish could be gotten rid of. And you sort of said, look, get in touch if there are things that you just think we should just dispatch. And I wondered, if you'd had many replies, or was it actually, did that fall on deaf ears?
So far, not many, but it's definitely something that, I want to bring round the loop again, that, if there are some, some things that are real blocks and things that we could do differently that would really change the way we can offer care to patients, let's talk about them. Let's bring them to the table, and let's think about how we might approach that, because I think there is, real opportunity and real merit to explore that, because sometimes they're much more simple than we might imagine, and sometimes they are tricky and they're not an easy fix, but at least talking about them helps unpick why that might be difficult, rather than sometimes things grow up through myth and not actually, based, as clearly in fact and evidence as people might imagine. So a conversation often can be a really good starting point for finding a way forward.
Great, that's really helpful, Sue. Thank you. I don't know if anyone else wanted to add anything on that particular point. If not, Mike, I might just give you, Mike Keach, I might give you a heads up that I'll come back to you in a moment if you don't mind. Just if there's any sort of particular high or low lights you think from a financial perspective, everyone would be interested in hearing about. Whilst I go straight to Afzal with no time for reflection, thinking whether there's anything, Afzal, you particularly want to highlight in terms of EPIC in particular, but our digital infrastructure in general over the next 6 to 12 months, because I know there are a few things that are going to be changing, and perhaps longer term. Is there anything that you want to talk to us about?
Yeah, thank you, Justin. So the most notable thing over the rest of the year really is going to be the next upgrade of EPIC in November, and we're now in the process of catching up, having been a little bit behind as we moved from DXE to Novosco. So in the first part of November, there's going to be a major upgrade to EPIC, which will take us through 11 versions of EPIC all in one step. And that will bring us a lot more functionality, which I think will become relevant as we go into next year, particularly around some of the improvement and transformation programs. The other thing that's going to happen sooner, hopefully by the end of July, is that we will be switching on something called Secure Chat, which is in essence WhatsApp or text messaging for EPIC, but it will work both on-site and off-site, mobile and desktop, and can be used for both patient-related and non-patient-related communications. And we will be coming out to all of the departments within the next few days, in fact, asking them to help us sign people up to using the system. In the longer run, there's a directive applicable to the Trust from the Secretary of State to get rid of long-range pages and non-emergency pages, ideally by the end of this year. So that will become the replacement. And then I think really in the longer term, as Roland alluded to earlier, so much of what we need to do in the future does need to be underpinned by digital. And I think it's important to reflect that digital in those circumstances shouldn't be seen as a bolt-on. I think it needs to be integral to the redefinition of various workflows and pathways, so that the conversation is really about, as those pathways are redesigned, in what way and at each step, and how can digital help in the most useful fashion. And the reality is people won't really, nobody ever phones me up to tell me that the network is working remarkably well today. What they do is they phone me up to tell me when things don't work, and rightly so, because actually what we need to do is to use digital to make things as easy as possible for people, so they can just concentrate on their proper job, if you like, rather than worrying about do they have the right kit at the right time at the right place with the right information on it.
Thank you, Afzal. That's really helpful, and I think it's going to be an exciting rest of the year, actually, with Secure Chat opening up and the EPIC upgrade. It'll be, I think, a big bonus. I guess one question that somebody like me who has no IT knowledge at all would ask is whether there's any prospect, as we become more regionally interactive, that any of the other electronic systems in any of the hospitals will have any prospect of talking to each other more clearly and purposefully, or is that unlikely to be the case?
At an ICS level, we're currently in the process of implementing a shared care record. So we've chosen a preferred supplier. It's just going through contracting, and the system will be going live. I suspect it was supposed to be ready for September, but the contracts haven't been signed yet. So realistically, I think we're talking about January at the earliest. at a practical level for CUH to begin with, we won't see that much of a change, in that the bulk of the data that will go in there will be either from CUH or from the National GP Connect system. But we already have access to GP Connect via Epic, via some software that we wrote here ourselves. So initially, CUH won't see that much change, but at the same time, Royal Papworth, NWAFT, local authority and community services, CPFT, are all committed to submitting data. And so over a period of months, you will start to see the richness of that data in that shared care record grow. And what we will do here is we'll link it in context to the patient's record in Epic, so that you won't have to log in separately. You'll be able to find that patient. Again, I think, though, there becomes an issue as to, once we have access to that data, how are we going to use it? And that again comes to, how are the workflows going to change, both for ourselves and for our community colleagues, so that actually there's a true benefit that comes from being able to access that data. You know, sharing data just for sharing's sake doesn't necessarily bring you a benefit. It's the downstream actions that turn into that benefit. I'm still working with colleagues at Papworth about a more detailed and direct link between us and them. It's been hampered by the fact, so they have the Lorenzo system, which used to be owned by our friends at DXC. In fact, DXC have now sold their healthcare business completely to a new company called Daedalus, and Daedalus are now wanting to take a different approach to that which CUH and Papworth had previously agreed. So there's some more detailed conversations looking at how that might work, but in due course that will be available as well. So I think we will have some point-to-point specific interfaces for where we have very significant interactions with others, but otherwise there'll be a more regional based shared care record with a slightly lesser level of detail in it.
Thank you, Estelle. That's really helpful to hear that. I don't know if anyone else wants to add anything on that IT front. Really useful. Thank you, Mike. If you're happy to give us a brief financial overview, and if anyone on the call has any questions, please feel free to put your hands up or use the chat function. Mike, over to you.
Great, thanks, Justin. I should forewarn people, I have 3 little people in the background, so any interruptions, I'll try to move seamlessly through.
No problem.
Probably just to say, I think I'd be having a very different conversation if we hadn't had COVID. So actually, as a result of COVID, we've had a very different financial regime. People will probably remember that we had a long-term plan that was set 18 months ago that had really stretching targets for us to deliver as a system. But with COVID, we were funded basically to cover our costs that we were incurring. And as a system, that means we've had something like 120 million of additional funding over and above what we might otherwise have expected. So really the challenge now becomes for us how we now transition out of that quite generous financial regime into something that we think is probably going to be more stretching into the second half of this year, this financial year and beyond. And I'd probably highlight 3 things just briefly as a summary. So the 3 areas I think I'll particularly be thinking about. The first is our COVID costs. So in response to COVID, we put additional funding into the organisation to support the organisation response. That funding is very clearly non-recurrent, so it won't stay forever. And as a system, the Cambridge and Peterborough system, in a half-year allocation, we've had about 60 million of that COVID funding. So we need to be thinking about how we can reduce our associated spend over the next 6 to 12 months. And that will clearly depend on lots of things like the prevalence of COVID in our community, what policy decisions are made around things like social distancing. But needs to be something
no apology required.
Needs to be something we're thinking about. The second area is around productivity. So Ewan has talked a bit around this on our operational planning and recovery. And I think we're clearly focused on that. That will allow us to get through more activity without increasing our cost base. And the third area is a sort of more traditional lens of a SIP, sort of transactional savings that as an organisation we'll need to start to refocus on. I hope you can still hear this with the background noise.
We certainly can.
So that's broadly what I'm thinking the next little period looks like. The other thing that's worth saying is, Roland touched on our capital programme. We have an extraordinarily big capital programme this coming year, and we had a big capital programme last year, circa £80 million of investment into our infrastructure and our estate. That's more than double what we usually spend, and supports Claire's theme of the strategy around building for the future. And what's really exciting within that is both the cancer and children's hospitals. We are incredibly fortunate as a system to have received support for those nationally to allow us to build properly for the future. The 120 beds over the next 12 months are great, but actually what secures our long-term future is the Cancer and Children's Hospital. And I'm going to stop before anything more drastic happens, and maybe hand over to others. Thank you.
Mike, thank you for that. That was multi-skilled, multitasking at its best, so much appreciated. And again, a very useful overview of where we are, and a suggestion, I think, from what you're saying, that things are going to be a little bit more challenging. We can expect that certainly in the next six to 12 months. Good. I'm not seeing any questions coming in, so I'm going to ask Roland to comment there. It looks as if you want to just come in there, Roland.
Yeah, so a couple of things. I think, Mike, that was a great summary. So a couple of things. I mean, I think on children's and cancer, as the dust settles on the announced 40 hospitals, it now looks like, Claire, I think there are going to be 13 that will progress towards building in the period up to 2026. And we're going to have both children's and cancer within those 13. So there are 30 odd hospitals who've been told to, plan on things happening beyond 2026. So we've got a lot of work to do to, breathe life into, the vision, Hugo, that you and Richard Gilbertson have developed around cancer, and the vision that we're hearing about from Canwell, Rob, David Rowich around children. So that's terrific. And then I think Mike's point on our financial position. So I'll just be very direct about it. It's a source of profound have the level of resourcing that some of our peer organisations do. And AFSAL does not have the resourcing for the most digitally advanced hospital in the country at HIMSS 7 that others do. And I mean, Mike, I know that we're going to continue to charge hard at sorting out really what the right financial settlement is for the hospital and the system. Because I think that would let us really get things motoring in the way that we want to. So, Justin, those are the only things I'd say. I think there's still unfinished business on what the financial package is here.
Okay, thank you,
Justin.
Mike, please.
I think that point on a financial settlement is really important. So we've performed really well over the last 12 months, delivering what we've been asked to do. We delivered break-even last year. We're planning for break-even in the first half of this year. But we need to secure that delivery in order to then support the conversation with the national teams that says we need a fair and reasonable financial settlement. That will require an improvement in our efficiency as an organisation, but actually it needs to be fair and recognise that Cambridge and Peterborough as a whole system needs to receive the funding that's required for its population.
Thank you. Important points. You're absolutely right. And Hugo, I don't know if there's anything else you want to add at all from the cancer hospital perspective, anything that you want to share with others, or is there anything else to add on that front?
No, so we're making very good progress, as just been said. We're optimistic. Roland just said we're optimistic that we're going to be effectively in the first wave of the new hospitals programme, which is a good place to be when you don't know where the other waves are coming from. So from that point of view, that's very positive, and we're engaging now in a lot of work with staff and patient groups just to try and really crystallise some of the key clinical elements that we want to go into the outline business case, which we're hoping to submit in the autumn. So I think people involved will have had invitations to various stakeholder groups and so on, and that's where we are. But we're happy to encourage as much staff participation really as possible, because we want to make it a good place to work and a happening place to be for staff, as well as a brilliant place to be treated for patients. So, but at the moment things are going well. So
brilliant. Thank you. As I said at the beginning, we circulate a recording of this, which actually generally has more people looking at it certainly than are able to join in real time. So a lot of this will be circulated for, and again, I'm grateful for everybody's time joining this evening. I'm going to just ask whether any of the other ME members who either have spoken or haven't yet spoken, which might just be Stephen, that's all. If there's anything else you want to add, or messages that you particularly want to get across that we perhaps haven't covered. No obligations at all. Roland?
I suppose the only thing I'd say, Justin, is I don't say this lightly, is it's remarkable, I think, over the last sort of 13, 14 months or whatever, how constructive and engaged and forward-looking everyone's been. And just looking at the list on the call, you know, I think about, say, the transplant team, and I said this with Mike Moore at the opening that we had of the transplant unit earlier this week. That when we discarded those organs last year, the engagement of the team as to how can we improve things in the hospital to make sure this doesn't happen again was just very constructive and forward-looking. And I think, again, if I think about movement, Prof McCaskey and team really getting started to make those 40 beds really work. Again, absolutely terrific. And that sort of mindset, I think, is something that's what ultimately, that's what enables people like Claire and Mike to go out on sort of raids to secure capital for the next 2 to 3 years, and then to sort of secure the Children's and the Cancer Hospital. So I just want to say that sort of attitude and drive is what takes us forward. And just thank you and well done.
Oh, well, thanks for those words, Roland. Really, really great to hear. It's 10 to 7. I suggest it might be good that everybody gets a bit of an early supper, perhaps. Unless there's anything else that anyone wants to say, and Mike Moore as well. I'm glad. Thank you for joining us. It's much appreciated. And if not, I'll thank everybody there. We might do this again in 18 months or so, as we did previously. But I'm really grateful for your time. Thanks very much indeed.